All right, I'll get started then. Hi to everyone who I don't know. My name is Evan Gale. I work full-time in the inpatient setting at Mass General, the associate director of the consult service there, and director of inpatient teaching for our fellowship as well. And I'm going to talk to you all about a subject near and dear to my heart, which is rapid methadone inductions in the hospital setting. I don't have any financial disclosures, but I do want to shout out to Jen Corpy, our pharmacist, for her contributions to this presentation. Oh, okay. Oh yeah, now it's picking up. All right. So my goals with this is that we're able to understand methadone steady state pharmacokinetics, apply it to rapid inductions, discuss the risks and benefits of rapid methadone induction in the inpatient setting specifically. I want to go through Mass General's experience with methadone inductions from 2016 to 2022, and then discuss the next steps where we go from here and advancing hospital inductions on methadone. So I do think it's really important to go back to steady state pharmacokinetics and just get a baseline for all of this. This is a good graphical representation of how we expect medications to reach steady state. This applies for methadone. You get one half-life, you get to 50% of that steady state at a single dose. By the time you get to 5, you get to about 97%. That's where that comes from. And so I know Zoe had showed this graph before, which is in TIP 63, about steady state methadone. Now, to me, this does not, let's see if this pointer works. Maybe not, but that first day after does not look like we've reached 50% of steady state. So I wanted to look into this because this is what we get when we look in TIP 63. It really, to me, looks like it takes more like 7 days to reach steady state. And I looked into the sources for this. Unfortunately, the original source from 2002 is an ASAM presentation that's not available online. The 2003 one doesn't actually go into the details of the graph itself. And so there's some things that are missing that I want to challenge a little bit. Number one, I don't really know the values along the y-axis, right? So it might be that this is totally linear. I don't know, but I really don't know. Number two, what's missing here is an elimination half-life. Like, I don't know what the elimination half-life for methadone is supposed to be in hours or days for this and how it applies to this graph. So I want to go back to this, the basic steady state graph, because I think this is the one that we should be using when we're thinking about methadone induction, right? I did a lot of looking into what is the elimination half-life of methadone. And of course, there's a significant amount of variability. The best thing I could find for an average answer is a source that also is cited on UpToDate, which is that the mean value is around 22 hours for elimination half-life. So to me, I think you could probably just cross out that bottom on the x-axis that says half-lives and put in days, and you would get a decent representation of the steady state that you're going to get with a single methadone dose, which is part of the reason why for TIP 63, after 3 days, you've reached 87.5% of that steady state. But I also think it's important to note that even at 2 days, you're already at 75% there. I think another question we have to ask, which sort of we already got into with Zoe's presentation, is why even deviate from the TIP 63 guidelines? But it's really because the reasons why patients either avoid coming into the hospital when they have necessary medical care, or they don't complete their stay, even though they have very serious illnesses, they're all the same: stigma, withdrawal, and pain. And I will say withdrawal influences those other top two ones. So when we're thinking about the risks and benefits of rapidly inducing methadone in the inpatient setting versus the outpatient setting, there's a couple things specific to the inpatient setting. So we've got more monitoring. We have nursing monitoring every couple of hours. We have physicians who are available to monitor the patients if we want to specifically see the patient at the time of peak methadone effects, really 4 hours after the dose, but somewhere between 2 and 4 hours would be a good representation. We can do that. We have the ability to split our doses throughout the day. I talked about the risk of self-directed discharge, but I also think we have to think of the risk in the hospital setting of overdoses and where they're most dangerous. They're most dangerous when patients are using substances on their own because of undertreated withdrawal or because of undertreated pain, because that's when patients tend to try and find private spaces like bathrooms and are not actually getting eyes on them from nursing staff or others. I will say, when we have rapidly induced methadone, as I'll go over, we've never actually had to give someone naloxone for reversal. But in that worst case scenario in the hospital, if we were to rapidly induce someone on methadone and we got to a point where we saw that they were sedated, and we were worried about their respiratory rate. We have these agents. In that worst case scenario, we can reverse it and go from there. Thankfully, haven't had to do it. So I'm not actually going to go over many different patients on many different studies on the inpatient setting. I'm actually just going to go over this study that was published last week in the Substance Abuse Journal, which is our experience at MGH over the last 6 years. So it's a retrospective observational analysis of hospitalized patients seen by our addiction consult team from 2016 to 2022. We had people who we counted as essentially new initiations of methadone. That meant you had to not have used methadone from an OTP setting for the last 5 days. You might still be connected, but the TIP 63 guidance says that after 5 days, you should be starting from scratch. So for us, we counted that as a new initiation. We excluded patients with hospital stays of 4 days or less because we really didn't feel like we could see a trend in their methadone dosing. In the end, we got 112 patients from the 214 that were initially identified that met this criteria. And then we looked at things like the initial daily dose, the maximum daily dose, the interval of escalation, and whether they were linked to an OTP at discharge. And of course, we also looked for adverse events, which are listed here. I'm not going to read them all through, but we will talk about them. So when we were looking at those adverse events, the key for us was what is the probability of the event relation to the methadone induction itself, right? And so we really differentiated this into 2 groups. So probably or definitely related to methadone would be if you had an event that occurred after initiation of methadone, where it seems like it's clinically plausible that the methadone could be the cause of the sedation, and we don't have any other factor that gives a more likely explanation. Possibly related or unrelated. So unrelated would be, for example, you have a patient, they're documented to be somnolent, but then you see that that patient was found, with a syringe or other injection materials. There was clear in-hospital use, or something that's very obvious to that state. There's also other significant confounding factors that would put someone into this possibly related situation. So if you had someone who has stimulant use disorder and they were documented to be sedated within the first 24 hours, even though you started a low dose of methadone, and then despite the fact that you continued to increase the methadone daily and the person was not sedated the rest of the time, that still counts as possible sedation, right? Similarly, if we have other sedating meds that a person was on and the pattern of sedation really fit with a sedating med given at night as opposed to the methadone in the morning, again, that's more on the possibly sedated side because that's not what we would expect from what we know about methadone's peak effects. So we looked to see, is there any difference in sedation events versus no sedation events based on mean starting dose or based on the final dose? And we tried to control for some of these other factors like age, sex, and length of stay. And so to just give you a sense of what we found that our average methadone dose was 32 milligrams. Again, a pretty big range, right? There's some folks who even started as high as 70, 80, or 90 milligrams of methadone. The mean maximum dose was about 77 milligrams, and the time from initial to peak was 5.6 days. But again, a big range there, right? From as low as 1 to 19 days. So this is the rate of possibly related or unrelated events. And I really do think it's important to remember that we are including possibly related or unrelated in this. So we have the most common one being oversedation, 28.6%, really very low rates of other of these. I mean, I can think of the one case where we had respiratory failure, cardiac arrest, and code blue, and I can tell you because I cared for that patient, that was someone who had very obvious in-hospital substance use, and that one was clearly unrelated. On the other hand, if we're looking at probable or definitely related events, of the 112 patients who we included in this study, we had 4 who had oversedation, about 3.5%. The way that we treated those patients was either to keep the methadone dose at the same dose for a number of days, or at the most go down 10 milligrams. There were no other interventions that were required. No other types of events were probably or definitely related to methadone induction, regardless of rapidity. So other things, there wasn't really a difference that we found between starting doses and having an adverse event like oversedation. There was a relationship between last dose and likelihood of any possible related safety event, where patients ending at a high 100 milligrams or higher had a higher chance compared to those ending at less than 100 milligrams. Obviously, there really wasn't a significant difference when we're talking about probable or definite related events. Other things to note, so we had a pretty good amount of patients who were able to successfully connect to OTP. 16% were connected to nursing facility. Of the rest of that group, 75% got into an OTP, 90% were referred. Probably part of that was the 19% of patients who still had a had a self-directed discharge. So, I think one way that you could possibly look at this paper is to say, well, the risk of possible sedation due to methadone is, 3 out of 10 patients, and it's significant. But I really do want to challenge that, because this includes a lot of patients where there's some very other obvious explanations, and we still, in our methodology, said if methadone's on board here, even if we have this other clinical plausible explanation, we want to consider it as a possible event. So this means patients who are withdrawing from stimulants, who get sedated in the first day that they come in when they're withdrawing, even as we start on a dose of methadone, and then are more awake in the coming days, they still get counted in this group. This means that patients who have some sedation noted at times where it's like an hour after they get sleep medication or clonidine, or at times of the day where it doesn't fit with peak sedating effects from methadone, they get included in this group. This also means that there was one particular chart where throughout the daytime, the patient did not have any sedation noted, but the nurse overnight was documenting that the patient was sedated at 11 p.m. They got counted in this group. So I really think that's important to point out here. On the other hand, the risk of probable or definite sedation due to methadone was 3 out of 100, or 3.5 out of 100, and none required any more intervention than at most reducing a methadone dose by 10 milligrams the next day. I'll also say, in terms of our self-directed discharge rate, it's more than we want it to be. We would like it to be 0, but 19% is less than the 25 to 30% that we might otherwise expect for people who are actively using drugs and have to go to the hospital. So there are significant limitations with the study that I want to point out. I'm not saying that the way we do things at MGH is going to apply to every single other hospital or every single area. We have a specific patient population. We have a lot of folks who are coming from an area where there's easily available fentanyl and fentanyl analogs, and we have a number of patients with very high opioid tolerances. That may not be the case everywhere. I also think it's important to note, we didn't include these patients who had 4-day stays or less than that because we really didn't think we'd see a trend. We probably missed a number of patients who may have not gotten the withdrawal control they needed to stay in the hospital and had self-directed discharges. I'll also say, when we're talking about the starting dose in particular, when we were trying to do this, that starting dose was the first dose the person was given. So some of those folks who got like 10 milligrams, that's really because it was the ED protocol, but then perhaps they might have gotten, more rapidly titrated when we saw them. So it wasn't as easy to pull out those relationships. And then I do think it's important to point out, because, we just went through what are all these different protocols that you can use. We don't actually have a standard protocol at MGH. We give clinicians leeway to start methadone and adjust it as they see fit based on patients' withdrawal symptoms. But it is a limitation, because we can't say this is how we're doing it and this is what we found. There's differences person to person. And of course, going with a retrospective chart review, there's going to be some limits to what we can actually pull out. We did our best to try and make sure that we had multiple eyes on this, having 2 different reviewers look over each chart. And if there are any disagreements about possible versus probable sedation or an event happening or anything else like that, having a 3rd reviewer come in and adjudicate. There's always things that you're going to miss in the chart, reasons why people might have been more rapidly up-titrated on methadone that aren't quite, easy to see, or reasons why, someone might be at higher risk if they were to have a rapid induction that we can't always pull out. So, my thought is, I think we talked a little bit earlier today about, what's sort of like the dose, what are some of the protocols that we can use? And my thought is here that Hospitalization overall, I don't think we have to focus so much on what the individual dose is, but just seeing this as an opportunity to induce patients onto therapeutic doses of methadone. We know that those subtherapeutic doses are the ones that put people at risk for overdose. So if we have the opportunity to get someone safely and rapidly up to a therapeutic dose, why not take it? When we do that, of course, there is a possibility of sedation, but generally we can treat that by either slightly reducing the methadone dose or keeping it the same for a couple of days. Or the other thing is, we shouldn't anchor on methadone as the reason for sedation. We should take a look into what are the other factors that are going on with this patient. And before we blame the methadone, are there things that we can adjust? So for example, if we have patient who's they're on some home clonazepam, they want to get on methadone, we're finding that they're sedated, and we want to go up on the methadone because they're saying they're in withdrawal, but we notice this is happening a couple times a day. That's probably a time to talk to them and say, hey, you know what? I want to go up on your methadone. There are times that you're so sleepy. It seems like it's more from your Klonopin. If you want us to go up on the methadone, we really need to talk about what we can do about this other medication and just help them make that choice or decide with you what they think is right. I do want to go back to pharmacokinetics because this is really the way that I see it. We all talk about destigmatizing substance use disorders and opioid use disorder and treating them like other medical conditions, right? So we talk about how for maintenance medications, we think of it the same way you think of diabetes or hypertension. You're going to need a long-term medication. This is what people do. It's the same when it comes for medications for opioid use disorder. Well, I want us to apply that same type of general medical practice thinking to methadone inductions in the inpatient setting. When we talk about antibiotics that have long half-lives like vancomycin or gentamicin, and we want to get them to therapeutic effect, we don't start them slowly with subtherapeutic effect. We give loading doses and get them to their therapeutic effect quickly. Now, I'm not saying that we should give people 200 milligrams of methadone on day one to get them to 100 milligrams the second day, but I do think we need to use the opportunity in the hospital to get people to a therapeutic dose more rapidly and in a way where we're monitoring them, like using that monitoring to get them there safely. So I do think in terms of our own studies, and to keep studying this, to keep learning about this, we probably do need to start standardizing some guidelines, at least, maybe not a protocol. I can tell you our current experience is that at Mass General, we might give for most patients anywhere between 40 to 80 milligrams of methadone on day one, starting with 40 milligrams for methadone when a patient comes into the hospital, assuming that they are not sedated, assuming that they are having a subjective complaint of withdrawal, and we do that rather than cow scoring because our experience has been that that's an operator dependent scale, and you have a lot of patients who are not going to be scored on cows, even though they're already feeling withdrawal symptoms that are making it difficult for them to stay in the hospital. Then, depending on a number of factors, which are listed here, and for time's sake, I'm not going to go through, we still want to have more methadone doses available for every single person because we don't expect that 40 milligrams to last for every single person for 24 hours. And so depending on those factors, we might consider 10 milligrams Q2 hours so that we can at least make sure that the patient isn't starting to get sedated after that 2-hour time frame, times 2 doses. Or for some of the folks who, again, we know that they have difficulty tolerating hospitalizations, we know they have a high opioid tolerance, we might even consider giving them 20 milligrams Q2 hours PRN times 2 doses. And I will say there are edge cases that fall even outside of this, although thankfully they're not too common. Another thing that we would probably want to formalize is that once we've done this, once we've taken day one to sort of use our split dosing and load someone with methadone, putting that all into one dose on day two, and then using our observational skills, right? We as addiction medicine physicians can make sure that we're seeing patients 4 hours after that initial dose, see them at the time of peak effect, and see what they look like. See if we think they're sedated or if we think that they're engaging with us appropriately and that we can continue on this path. I don't know that I entirely agree in the inpatient setting that we have to stop at 80 milligrams. I think our study suggests that 100 milligrams is probably about the point where we should consider holding for 3 days and reaching that steady state. But, I will point out that there are certain patients where we see them and at 100 milligrams, They're quite awake. They're feeling uncomfortable. They're talking about not necessarily being able to stay in the hospital or refusing certain tests. And for those patients, we probably still want to keep rapidly titrating them up until they get to whatever dose they start to feel more comfortable at and stick and stay for 3 days there. So the last thing that I'll say is that, we can continue studying this in the inpatient setting. We can keep doing everything that we want in the inpatient setting that we know we can monitor them. We know we can get them up rapidly, safely, and do that. But to truly see how this is going to affect someone throughout their care, we need to partner with OTPs. And I hope if you're interested in this today, that you'll think about this, because we have to see what happens when a patient who is stable on these doses for a couple of days in the hospital then goes out to an OTP setting or even to a nursing facility setting. And are there other risks or benefits that we can't monitor? I went through that really fast because I was worried about going through time.